Good morning. So you can see that Corona doesn't scare me. So it is my honor to be here. I had promised to come here at least once, and it has taken me a few years to be able to accept, so I'm very happy to be here today and to talk to you briefly about what can we gain by integrating the patient's perspectives in when we develop guidelines. Let's see if I can make this work. So the issue of being short is that I can't see my slides, so I'll try to see it there. I can't see, you know, that's you because you're tall. I can't. Now I can see it. You are tall for me. Thank you. You are tall compared to me. All right, I can see it over there. Very good. So as an asthma officer, I have to disclose every single thing that I have done. So there's in my disclosure slide. And I don't have to tell you that the outcomes or the evolution of the outcomes in advanced breast cancer have been very slow, very mild as well. So these are two results coming from what we call the decade report, which look at what happened in the advanced breast cancer field from 2005 to 2015. And you can see in the top that in terms of survival, the percentage of patients alive at 5 years just moved 2% in 10 years. So it's really not something to be proud of. And in the bottom, you can see that even in terms of quality of life, despite the fact that we had some important advances in the past, now it seems to be stalled and no more advances seen. Now, many years ago, we started all this effort. It was around 2006 when the year before, these two surveys and publications came out showing how the patients with advanced breast cancer felt. They felt abandoned, they felt alone, they felt even guilty because they had a relapse, so probably they did something wrong. This is how they felt. And we repeated one of those surveys about 10 years after that. And you can see that things have changed, but they have not changed as much as we wanted. So about 60% still feel very much alone. So there's a lot of work to be done. So when we trying to face this problem, which is a difficult problem, and when we started, we looked at early breast cancer and said, okay, what can we learn from early breast cancer to apply in the metastatic field and make the metastatic field advance as much as we did with the early breast cancer, because early breast cancer is always given as an excellent example of what we have done in terms of working in a multidisciplinary way, reducing mortality in a very substantial way. So what was it that we could apply? And for me, I focus on these two things, on developing high-quality guidelines, which did not exist, at least outside Germany, but they did not exist, and to focus on multidisciplinary care, which for a long, long time had thought to be important just for early breast cancer. So I must tell you that when I started, half of the field of breast cancer said that it was not possible. First, it was not possible to have consensus guidelines because everyone had their favorite drug for the metastatic setting, and no way everybody would agree on common guidelines for treating the disease, which fortunately we have proved them wrong, and there are principles that everybody can agree upon. Then if you have a favorite drug, that's a different story, but it's not the major point for the guidelines. Also for multidisciplinary care, when we started, I used to ask a question in the room and say, who discuss metastatic cancers in your tumor board? And in the beginning, it will be extremely rare that someone would do that. And now things have changed, and more cases are discussed in the tumor board. And it is possible to do so. It takes time, of course, it takes commitment, but it is possible to do so, and it changes the quality of care for these patients. So we started to work, first creating a task force, then moving to a dedicated conference with consensus guidelines, and the last one took place last year with about 1,500 people from 90 countries. So really an international effort. So I'm working on the manuscript that should be out in the next couple of months, but the guidelines themselves are already finalized and have been presented. So one of the things that we decided from the very beginning is that patients and patient advocates had to be full and equal partners. So not really someone to have just to say that we have done a good job, but to really be involved in all the discussions. And you know, in the beginning, I heard a couple of comments regarding the advocacy field. And I've seen at least Eva, I've seen. I don't know if there is someone more advocates here, but the comment was that in the advocacy world, they don't get along with each other. They're always fighting with each other. They don't collaborate among themselves. And this is true in all countries, and it's true all over the world and between international groups. However, I think with ABC, we have proven that if you have a good goal, a common goal, something that where everybody agrees upon, you can get people working together, all of them, from the same and from different countries. And you can see that there are a variety of people there, and these are just the tip of the iceberg. There are a lot of advocates working from developed countries, from developing countries, learning from each other, and it is possible to work all together. And by the way, I think the same thing can be said about us, physicians and researchers. We also have lots of groups. We don't always talk to each other. We sometimes run parallel and competitive research instead of collaborative research, but this is also changing. So I think the advocacy world has also changed and is ready to work in collaboration. Now, after we started the ABC effort, we have seen that besides doing the guidelines, something else started to happen, and showing that there was a true strong need in the field, and that was a huge movement of lobbying and of fighting for the rights of the patients. Not just access to drugs, not at all, but access to high quality care in everything that that entails. And that's why we have moved further ahead from the conference and created the ABC Global Alliance. And this started as an initiative of the European School of Oncology, and last year it became an independent organization. So until last year, we had 180 members from various countries around the world and all continents in the world. So really the objective here is to get all types of stakeholders who want to do projects for advanced breast cancer and work together. And it is not easy because people come from different views. So there is the view of the industry, which is a very focused view. There's the view of the patient, there's the view of the researcher, and even of the policymaker and the payers. We have to involve them more and more because in the end, they're the ones who take the decisions if something is going to be paid for or not. So the aim is to work together and also to help those countries that don't have a huge history in advocacy and lobbying, instead of starting from zero, to take the resources that already exist and move forward from there. When I was thinking about the talk, thinking what can I say about this that I have not said before, it's very hard. So I made this list of things that you can do to integrate patients' perspective, both in the guidelines and also in all things and all decisions that are necessary for the quality of care. So define priorities together. And I will show you what we have done towards this. Also define the goals of treatment, and always remember that for the metastatic setting, this balance between quality and quantity of life is very very delicate, and it's also very personal. I may give a different weight to quality, and someone else may give a different weight to quantity, and we have to respect that in the perspective of the patient. So acceptable toxicity is something that everybody says when presents a trial, right? The toxicity was acceptable or manageable. Everything is manageable, but it should be defined by the patient, not by us. And I'm going to make just a parenthesis. I have learned a lot of things about oncology in Germany through my Portuguese patients who live in Germany. And I want to make you just one note. When assessing the toxicity, consider also the cultural and the psychological characteristics of the patient in front of you. I think that German women are extremely strong. They endure chemotherapy regimens that by no means a Portuguese woman would endure. And I'm telling you this with utmost respect. But I'm telling you that my patients, the Portuguese patients who live in Germany, they told me that. They said, I feel terrible because the German patients, they seem to tolerate it perfectly well, and I'm dying with all this chemotherapy. So I think there's also probably genetic determinants for toxicity, polymorphisms, all these things. But you have a very strong community of women, but not everybody has. And manageable and tolerable has to be defined by the patient, not by the oncologist. So please think about that. So that's the only thing I will say about that. Then we also need to define together the endpoints that truly matter and define together what is really a meaningful benefit, as well as some words about communication. And then in the end, if I don't take too long and I'm not kicked out of the podium, I will show you a very short video. It's 1 minute, 30 seconds of our new awareness video that was launched this week. So defining priorities together, this was the first thing we did, really doing a needs assessment of the field and defining 10 objectives, 10 goals that are achievable, not a wish list, but 10 goals that we can achieve in a period of 10 years. And I know that you will look at the first one and said, well, if in the previous decade there was only 2% increase, how do you want to double the median survival? I think it is possible that we do this because we have made substantial advances in 2 of the subtypes. So we all know the advances of the HER2 positive, and it takes a while for us to see the effect of the advances in the population. But we are now seeing that the median survival of HER2 positive is no longer 3 years, but it's closer to 5. And I think probably with the CDK4/6 and other targeted therapies for the ER positive, we will be able in a couple of years to see also that median survival go up. So we will still have the triple negatives pulling down the median, but I think it is possible that we will double the survival in this decade that we are living. At least I want to believe we will. So the other goal that we had is to finally be able to determine how many advanced breast cancer patients exist. And you all know about this data of incidence, mortality, and prevalence. But in no way, in no country, we have the prevalence of advanced disease. So we don't know how many people are living with metastatic disease. There were a couple of efforts, and I always give the example of Germany as one of those efforts. Also in France, there were efforts of establishing nationwide registry programs to be able to understand better this disease. However, this is not sufficient, and I just came from a meeting with IARC, and what we are trying to do is to establish in at least European wide for starting, and then we will see how we can go worldwide, but also in the US. So the SEER database people were also there. The problems with establishing a registry that tackles relapses have to do with the way we do follow-up, right? The majority of our patients are discharged from the big centers. They go to the community, so how can we track down the patient and make sure that we identify all the relapses? This is difficult. And we also have to define a minimum set of data that's not too cumbersome for the registry, but that provides the data that we want. And of course, harmonize definitions, hoping that in the end, we will reach to know the prevalence of advanced breast cancer. Now, what about defining the goals? So I think everybody here in this room knows very well that the goals of treating advanced disease are a bit different from the ones treating early disease, and that this balance of quantity and quality of life is very important. So in the last ABC, we updated the list of factors to take into account when deciding the treatment, and we added a couple of biomarkers that we believe now are already sufficient, or the level of evidence is sufficient to recommend them if you have access to the targeted therapies. It's not for all countries. If you cannot give the targeted therapies, it's useless to look for the biomarker. But so this is a list, not a complete, but already an extensive list of everything you need to take into consideration. And you will see that there are biological factors, there are disease-related factors, but there are a lot of patient-centered factors that you need to take into account as well. And if our goal is to prolong life as long as possible with a good quality of life, a couple of notes. So endocrine therapy is the preferred choice when you have an ER-positive disease. And when you're using chemotherapy, look at the toxicity profile. For some patients, neuropathy is the side effect they do not want because they need their hands for their profession. For others would be alopecia. So talk to the patient, see what they want to avoid. Don't be afraid to dose reduce. I think everybody has the mindset of early breast cancer where dose intensity is crucial for the final effect. But in the metastatic disease, that is not the case. So it is okay to decrease the dose according to the toxicity, prefer oral, and also look at the patient preference. Now we also, let's say, highlighted this even more by saying that health professionals should be ready to change and adapt treatment strategies regarding to taking into account several factors, including side effects, quality of life, patients' priorities, and life plans, and attention to other needs such as home, family, job, and social desires of the patient. And finally, about this topic, I would like you to have a look at this paper that describe what they call the taxonomy of the burden of treatment. So actually, it was then translated into the lay language in cancer world, saying, why does it being a patient becomes a full-time job? So we look at the patient in front of us as a patient, but she or he are not a patient. They are a teacher, a doctor, a surgeon, a lawyer, and by misfortune have a cancer. But their lives don't have to turn around everything they have to do for their disease. Now about endpoints, I'm not going to go into the endless discussion about PFS and OS. I think I have been called more names because of this than anything else in my life. But it's okay. I still stand that PFS is not a good final endpoint. It doesn't mean it's not a good endpoint to evaluate if a drug has some efficacy, but it cannot be the only endpoint that we aim for. Otherwise, the mortality will continue to be so high as we have it now. Now, we also say that quality of life is a crucial endpoint. But if you look at the quality of life, let's even just focus on the trials of CDK4/6 and the quality of life of those trials. There are some disparate results that I really do not believe it's because the three drugs are so different. It has to do with the methodology that was used to measure the quality of life. And much of that has to do with the fact that we are using tools developed for early breast cancer. So there is no specific quality of life tool for the metastatic setting. And this is something that is an alliance project. The EORTC Quality of Life group is developing a specific tool to measure quality of life in the advanced setting. It will be good for breast, but it will then be able to be adapted for other cancers. And unfortunately, this takes as long as to develop a drug almost. It has phase 1 to phase 4, and it's still on phase 1, but I hope in a couple of years we will have this tool ready. And of course, PROMs and patient-reported outcomes are becoming more and more important, but we have to pay attention how we measure those as well. And I don't have time to go into the details. I put there Concado on purpose, because I think it is an extraordinary tool that if we learn to use it more and more, it will really facilitate our work, and it will help the quality of life of patients. Now, defining together what is meaningful benefit. And I put there a couple of thoughts just for us to think about. So not everything that is approved has a meaningful benefit. And this should not be the case, but unfortunately, particularly FDA approves just about anything. So we need to be careful and not focus on what the regulators do as a sign that that is a meaningful benefit. I would go on discussing why they do that, but I'm not going to do that now. Then, not every positive trial is really a step forward. Okay, so be very critical when you listen to someone presenting a trial. Ask them the absolute benefit, not just the relative benefit. Don't have them go up there and say, this is 50% better. If the 50% is from 1 month to 2 months, so what? That's 50%, but does it really matter? And even if it's me, we're presenting the results, be critical. Be critical, ask, not tell them, stop focusing on their hazard ratio. Show me both, the hazard ratio and the absolute benefit, and then I'll decide if that's truly a step forward. And then I think we are also used to fashionable things. And we have this tendency as humans of thinking that the new thing is always better than the old one. And I'm sorry to tell you, but the best endocrine therapy that we have is tamoxifen. It is. It's an old drug, but it's the best one we have. I haven't seen any spectacularly better drug than tamoxifen. And trastuzumab is also one of the best. Everything else you add up, okay, gives you some small added benefit, but those two are the ones who are changing completely the outcome of breast cancer. Now, costs should be linked to benefit, and you will see that it's not. And I think we are all responsible for decisions. And I grew up with a generation that said, I don't care about cost, I focus on science. I think my generation and all the other generations now, we cannot say that anymore, because what we decide is intensively dependent on the cost of things. And I will stop here just a moment. I think probably most of you have heard that Aaron Goldrich has died. So he has been instrumental on improving the outcomes for early breast cancer. But he was one of those who said, I don't want to know about cost. But I think at the end of his life, he changed And he said, not anymore. I used to say that, but it's not possible anymore. And I wanted to pay my respects because he was instrumental in changing the outcome of breast cancer. Now, we have tools to help us decide what is a meaningful benefit. And for lack of time, I'm not going to go into the details. You have the ESMO tool and the ASCO tool. For the ESMO tool, which is more user-friendly, you have this classification for both early and metastatic, and that helps you decide the ones who classify highest should be the priority. Then if you have enough money, you can go for the ones who have an intermediate score. But even if you have a lot of money, it's useless to go for those who have a low score. And they have taken some premises when calculating this score, and unfortunately, in the beginning, they didn't ask the patient before taking these premises. But they have done it so now for the new version, and the patients have evaluated the score and have agreed with these premises that cure takes precedent over deferral of death, in a way saying that survival takes precedent in PFS or something else similar to that. And that surrogate outcomes are not always the best way to look at the true impact of a treatment. 2 or 3 just notes for you to think. So I told you that not everything that it's approved has a meaningful benefit. Look at the median survival gain of drugs approved by the FDA, 2.45 months. So there you go. But EMA is also not very bad, much better. If you look at the calculation of drugs approved by EMA that have high scores, only about 10 to 20% actually have a meaningful benefit. And the authors of this paper said that it's because lots of trials use surrogate endpoints. And I will advise you to go and look at this paper as well. This is a complex graphic, but I put this, 2 arrows there for breast cancer, early and metastatic. And when you see a green triangle, it means that the surrogate is positively linked to the long-term outcome. In red are the ones that are not. And although you cannot see very well, I can tell you that there is none for breast cancer, neither PCR for early breast cancer, and I know I am in the land of PCR, but no, not even PCR, and not PFS for the metastatic cancer. And finally, this other study has shown that the price has nothing to do with the benefit. Now tell me another business where the price has nothing to do with the quality of what you buy. So I think we are all responsible for that. We pay millions for something that is not worth millions. And it's our fault. And so finally on this topic, if the slide moves on, this is the benefit shown in the NALA study. So it has a bad control arm. So capecitabine plus lapatinib is inferior to trastuzumab capecitabine, and yet they use the inferior control arm. And even compare with an inferior control arm, they have a 2 months difference in PFS. And guess what? It was approved this week by FDA. Now, 2 last points. So communication is crucial. And I'm not going to go into the details saying that we need to communicate what are the true goals of treatment for the metastatic setting, and we need to do that, as I mentioned before, in accessible language, respecting what the patient wants to know and the cultural differences. We should encourage the patient not to come alone to the appointments, because we may have to give a news of a progression of disease. And we would be able to do that much better if we would have training in communication, and many of us had to look for that training because it was not provided in our universities. Now it's changing for the new generation. So one of the things we try to do in the Alliance is also this, provide communication training, both for the health professionals, but also for the patients and the patient advocates. And then finally, my last point, and I hope the movie works, is to say that we have still to fight a lot against stigma. And when I present this, that people think that breast cancer is all the same, it's all the pink movement, or it's cancer, so it's worthless because they will die anyway. You may think that, oh, not in Germany, not at all. But the fact is that this stigma happens in all countries. And this was one of the questions of the decade report, and it goes from developing and developed countries, asking 1 out of 4 or 1 out of 5 people in the public think that metastatic breast cancer patients should not talk about their disease, including in Germany. So a lot of stigma we still have to fight. And so my final, hopefully my final thing would be to show you this very short movie that I hope has sound, and I hope it works. He promised me.
It sometimes feels like a price has been put on our life, and that isn't right.
They just look at you as a walking corpse.
You know, I am living probably their worst nightmare.
It is treated like a curse.
They can't understand that there's no happy ending, no getting better.
No, let's not use the money for treatment because she's gonna die anyway.
Thinking about my kids is difficult.
I am
Advanced
Breast cancer.
Thank you. Thank you very much.
It's difficult for me to speak, actually. I'm touched, and I was touched by this Global Alliance meetings, and if you learn about these patients, I think you've done a big job, and thanks a lot for coming and for doing all this. And you, of course, have to put up the photo of us in your office.